Hi everybody, welcome to today's episode of the eGPlearning Podblast. Today we'll be covering a GDPR themed episode where we're looking at the variety of different apps that you can use to communicate with each other which are GDPR compliant, talking about GDPR and its principles, as well as covering some feedback from our previous episodes. Hope you enjoy.
So Gandhi, I hear something big's happening in May. What's going on?
Well, we've got the royal wedding, Andy. We were meant to have a royal baby, but that's already happened. FA Cup final?
No, Gandhi. GDPR.
Oh, yeah.
Have you heard about GDPR?
Oh, who hasn't heard of GDPR?
And those people that have heard about it in general practice all seem to be a little bit apprehensive and scared. So probably a good time to talk about it and share our feelings, offload, maybe make ourselves and other people feel better.
Hopefully. Well, yeah, so today we're going to have a GDPR themed episode for all of our lovely listeners out there. And we hope you enjoy it today. First of all, we want to thank all of our current listeners, and we've had quite a few comments recently. First of all, a shout out to Ben Gowland, who runs the General Practice podcast.
Hi there, Ben.
How are you doing? For our listeners, we've actually had a very interesting chat with Ben recently, and we'll hopefully be featuring on his podcast in a few weeks' time.
Yeah, we've had some interesting mentions on Twitter. So Jacey Meloday at Jacey_Melody. And she really enjoyed our review of Welltory and gave us a nice comment on Twitter.
Mm-hmm. We had quite a few likes from Moodpath, who we covered in one of our earlier episodes, as well as Shubs Upadhyay, who runs the @2GPs in a Pod podcast. Well worth a listen if you like hearing about interviews and stuff. Todd Berner and the Keck Graduate Institute quite liked our stuff on Welltory as well.
We had some interesting feedback on the March episode. At Digital Pharmacist, Mohammed said that he's going to have a listen. Hopefully he's done that now already. Mm-hmm. And we also had a comment from Dr. John Griffiths, who thanked us for mentioning him. And our regular listener, Sonari Kinra, also commented that her husband has been enjoying listening to us on the way home. Mm-hmm. Fantastic.
And if you do listen on iTunes, you'll probably see a few reviews that we've had lately. We've had some really good feedback from some listeners, particularly asking us about our show notes by Marcado Escano. But we do actually have show notes, so we've shared that with him. And probably one of the most encouraging one we've had was from Jules Hannaford, who actually works in Hong Kong, and who wrote about the fact that she loved the informative way that we covered things, and she was going to share it with her students who are aiming for medical school. So hopefully inspiring the world now.
Yeah, fantastic. Going global. That's really good.
Definitely.
So Gandhi, what have you been up to since we last spoke on the podcast?
Busy as usual. So first of all, I've been, thanks to all my local peers in Nottingham, I've been voted as a NOTS LMC representative for the area.
Hooray, congratulations.
Yeah, I'm hoping I can do a good job for everybody and represent primary care effectively. I've also, hopefully you guys have been listening to us on YouTube. So our Podblast is now on YouTube. We're spreading our wings.
Great. Yeah, and so what have I been up to? So I had a great time talking to Keith Grimes. I think, hopefully you've all listened to the podcast interview episode. Mm-hmm. Keith talked about his life as a medical VR guru and how he's promoting medical VR. And we also touched on some areas of sort of following your passion and how to balance your life around tech and medicine, which is good, and learned some lessons there myself. Also, and if you go on my blog, avoidingpuddles.com, you can see that I was involved in a student documentary. Shout out to Oliver and co from Vision West Nottinghamshire College, who came and filmed me in surgery as I talked and said a lot on the subject of artificial intelligence in medicine. They made a great little documentary, so check that out.
I do like the video from that. It's quite interesting. And speaking of a little bit more of different media, one thing I wanted to share with our listeners, hope you've had a chance to see it, but we've recently run a quiz that looks at what kind of GP you might be. It's had some really interesting uptake and some interesting answers and feedback. Definitely worth having a look. It's on the Facebook page for eGPlearning. Feel free to have a look and see whether or not you agree with your results.
GDPR is a complicated piece of European legislation that will be coming into place on the 25th of May 2018. It is yet to be tested in a court of law, and there are many unanswered questions about it. Gandhi, Hussain and Andy Foster are not lawyers. They are not qualified to give you advice on this topic, and you should not listen to them. However, they will talk about their own concerns around this issue, and hopefully we can all learn together and generate some action points to move forwards. So Gandhi, down to business. GDPR. What is GDPR?
So GDPR is the General Data Protection Regulations that come into force on the 25th of May, hence why we're talking about next month and things. And this replaces the Data Protection Act that's been running for the past 20 odd years. Important thing to remember, GDPR is still in effect regardless of what happens with Brexit. So, all the things we're going to talk about, I'm afraid, even when Brexit happens, you still have to comply with these rules. But yeah, it's pretty game changing, isn't it, Andy?
It is, yeah. I think the thing that's caught a lot of people's attention is the maximum penalties for non-compliance with this regulation, which I understand are enormous and crippling. 4% annual global turnover, like any of us have global turnover, or
20 million.
20 million euros, whichever is greater. So the penalties for non-compliance are potentially enormous. Any other big changes that are coming through with GDPR, Gandhi?
So GDPR focuses a lot on in terms of the way that you use data and how you allocate it and how you, I guess, in a sense, map it. And there's some key role changes as well. So one of the new roles that's been created is called a data protection officer that certain practices will have to have. And the biggest change I think that will affect practices is the way the subject access requests will change. So previously, for those who know about it, when you had a subject access request come in, you had 40 days to process it, and you could charge up to £50 for a printed copy and up to £10 for the electronic copy. As of 25th of May, that's no longer the case. The time frame goes down to 30 days, and you cannot charge at all.
So big implications there. So Gandhi, what are the main ways in which practice might be affected by this new European regulation?
So I think what this means for practices is there's, first of all, new roles that practices have to consider, mapping the information and the flow of information itself in particular, and more importantly, you have to be able to justify everything that happens as well, so that's key. Security of data is going to be a big one. Subject access requests is a key point that we're going to talk about. Privacy notices, a little bit annoying, but we're going to have to look at those as well. And legal requirements to report breaches to the ICO, and the time frame for that is quite narrow. You've only got 72 hours basically to do so. And did we mention the penalties, Andy?
Yeah, those enormous penalties.
Yeah.
So Gandhi, who is your data protection officer at the practice?
Well, at the moment we don't have one. We're still trying to figure out how that works. I've heard from several areas that the CCGs are trying to support practices by creating the data protection officer role. That doesn't seem to be happening everywhere, and I think we're a little bit...
Sadly not in Nottingham City so far.
Yeah, we're a little bit upset about that, if I'm being honest. The fact that they're leaving us to flounder to a degree with this compared to other areas. But hey, that seems to be their decision and how they want to support primary care.
Yeah, so Gandhi, this data protection officer role, what is it? What are their responsibilities? This is one of the new roles to be created.
Yeah, so their responsibility is basically to understand the flow of information and how that works, and particularly keep an eye on everything. Basically, they're the responsible person outside of the data controllers, which is a role that's already existed but is a lot more clarified. So that's effectively the practice in our situation. So whether that's the practice or the partners of the practice, but basically it's the organisation itself. The other role that is important to be aware of is the data processor. So this is the person that actually does all the processing of your data. Now, most practices will probably be one or two individuals, depending on the size of the practice, and potentially more if it's a significantly large practice. But these are the people that basically process all your subject access requests, all your information requests from other areas to share information and stuff. So that would be your processor as such.
Yeah, so I suppose practices can find themselves occupying a few of those roles. So in one sense, the practice is the data controller, the holder of the information, the controller of that information on behalf of patients, our customers. And on the other hand, we also process that information, so have that separate role. And I suppose we may also be data controllers for other organisations who might process the data we hold as well. Lots of layers of complexity to this. So so when other people are running reports on your data to see if you've achieved QoF or to see if you're compliant with CQC, they are then occupying a data processor role, but you are still the data controller and need to be assured that they are going to follow the new regulations as laid out in GDPR. So quite complicated.
Yeah, just to say the least. And I guess part of that is then rolled into the mapping of the information. So, you can't really understand that whole process unless you've mapped where all your data is going. And unfortunately, in primary care, we have so many different ways that we get our information. I mean, even if you just think about the obvious ones, we get information from the patients that we document in the records. Well, then we've also got information that we share, for example, with secondary care, tertiary care, and community services to support our patients. We've then also got information coming into us, like requests from pharmacies about processing prescriptions, requests for sharing of information about referrals in terms of community support, that kind of stuff. Subject access requests that we're going to talk about a little bit later, and information for things like insurance companies, solicitors, all that kind of thing. And then even smaller things, so your practice meetings, they actually have information in terms of what you may be sharing if you're doing a significant event analysis, if you're talking about policies that will change the way that patients run. And then don't forget the stuff that involves the staff. That's included as well. So pensions information, HR stuff, how you manage your staff.
It's personally identifiable data, isn't it?
It's all personally identifiable and therefore applicable under GDPR.
Yeah, so Gandhi, I've been sort of trying to get my head around what a mapped data flow looks like. I don't know whether you've done any of this at your practice. I genuinely don't know. But what is that process? Because we're supposed to be doing it to understand what the data is, where it is, what are we doing with it? What does that look like?
So at the moment, ours is basically a massive Excel spreadsheet. It's about 5 sheets big. So yeah, loads of different data points and stuff. I think ultimately what we're going to end up doing to make it as easy as possible is just to create some workflow charts that show this is where data comes in, this is how it's handled, and this is how it's processed. And that's to make it easier for for example, our admin staff, as well as our GPs, because, I may be slightly tech the file and that kind of stuff, but even I'm struggling to comprehend a lot of this because it's just so complicated, and I think visual data helps, so understanding where things are going, but ultimately it's going to be a process. I think this is not something I think people are going to get straight away from day dot. I think the key thing is we just have to be making efforts to make sure it's being done, and more importantly you kind of need to start now if you've not already done so.
The clock is ticking. It sounds like you're a little bit further along the line than we are at the practice, Gandhi. We're still getting our heads around how to get started on a lot of the aspects of this. One thing that is worrying us, and seems to be the main thing that people talk about actually, is the subject access requests. So this is where patients, and they always, in the old Data Protection Act, they were entitled to request copies of the information that we hold about them. But we were permitted to charge a reasonable charge for processing and releasing the data. That's things like getting it on the CD-ROM, checking there's no third-party data there, printing it out and providing it with them. But we won't be able to charge them anything anymore in an environment where people may be increasingly aware that they can request this information. So just joining the dots there, Gandhi, are you worried about this at your practice, and why?
So particularly for us in St Anne's, we're massively worried about this because we have a lot of subject access requests that come, whether it's from insurance companies, whether it's from solicitors, whether it's just information for sharing, that kind of stuff, and it's a lot of work. And patients may be thinking, well, why should you be charging for that? Well, it takes administration time. So as you mentioned, there's the issue of copying that information into a format that can be used. It's not as simple as just clicking a button, because actually then you need to sift through the data to make sure it's appropriate to share, particularly those third-party references. In an area where we've got, for example, a lot of safeguarding cases, there is a lot of third-party information that's stored on those records for appropriate and safe reasons that needs to be looked at, clarified, and made sure that it's appropriate for that to be safe. The charge didn't really cover the costs of that, but at least it meant that it was in some way manageable, so at least we could pay some admin staff to kind of do that. And the GPs then obviously end up rubber stamping a lot of this to make sure it's appropriate and correct. Without those funds, we're basically doing this work for free that we used to be paid for, and this is unfortunately a theme that we see in primary care often, and it just hits that bottom balance even more. And I can definitely see some practices are going to struggle to work out their costings as a result of this, and it's another nail in the coffin in terms of primary care funding.
Oh gosh, that sounds bleak, Gandhi.
Well, I think many people are genuinely worried about this.
No, it is very worrying. I'm not sure we've got an answer at our practice either. I mean, are you going to change any of your processes? Are you going to do anything different to facilitate compliance? I know that we're thinking, at the moment, it tends to be a GP who will look for third-party references within notes as they're released, and we're exploring the idea of using other members of staff appropriately trained, perhaps even facilitated by using keyword searches, going through documents, following a bit of a protocol to try and fish out sensitive third-party information. And we're wondering if that will enable us to reduce the burden on the practice of having to do this extra work. Are you guys looking at any of that?
So we've already done all of that.
We've done that already.
Yeah. So we do that already. We pay an admin staff who's very well qualified and effective at doing all this stuff for us. It still takes time. I mean, an average set of notes can be a good 2-3 hours when you're looking at the third-party data in terms of checking it, crossing it out if it's not appropriate to. And this is something like, you've had to document somebody's phone number to contact with regards to a safeguarding case. Well, we can't share that information with somebody that it's not meant to see. So that has to be crossed out in a sense. And that takes time when you're having to consider that some patients will have notes that are literally hundreds of pages large. It's interesting if patients could actually see the size of their medical records. Sometimes they'd be shocked at how much.
Or know how much they weighed.
Oh yeah, definitely.
When printed.
When printed. And yeah, people say, why not just do it electronically? Well, you still have to go through the data. You still have to search through it. And that means literally somebody going physically through and doing it. I know that there are some companies out there that have tech resources that can try and help you do this, but they're still at cost.
Yeah, and we use a company, I forget the name, or I would give them a shout out, to prepare the data for insurance report information. The chap comes in, extracts the relevant data, pops on a CD-ROM to go to the insurance people. But there's a much simpler and well established way of getting that information out in a safe way that they follow. I had a conversation with them. I said, are you going to, have you got a pitch, a way, of supporting practices to redact third-party information on these subject access requests under GDPR? And he said, no, we're not addressing that. That remains the responsibility of the practice to make sure that information is redacted. So it sounds like we are pulling our hair out about this. If anybody out there has a solution or knows of a company that has a solution or any way to help practices, then tell everybody about it, because we're all facing a bit of a headache with subject access requests.
And I guess the next one is privacy notices. So this is a slightly different element to the GDPR. Do you want to fill us in, Andy?
Yeah, so it's important that holders of the information, so the data controllers, inform the people whose data they hold about what they hold, why they hold it, how they process it, for what purpose they process it, so that these things are justified and that information is readily available to their patients, customers, clients, and that it's easy to read, that it's easy to understand, and that it's there. So, and this information is referred to as privacy notices. So practices will have an obligation to provide these privacy notices. I think the suggestion is that these would be made available on the practice website for people to have a look at, to read through if they are interested in checking out their rights and seeing that we are controlling their information correctly.
It was interesting because when I first heard of this, I thought this was just simply a notice that you needed to put up that kind of covers everything, and actually, you kind of informed me that that's not really the case, is it? Yeah,
well, in preparation, so that's what I thought too, but I've been looking at some of the guidance from our local LMC and from the BMA, and actually they've been providing some sample privacy notices for practices, which are actually a really good resource, and I think we'll signpost to those either at the end or in the show notes. And actually, it would seem there is a requirement to provide a privacy notice for the different instances of data processing that we might do, and in particular where we may be working with partners in terms of working with that data. So there are different sample privacy notices for how CQC might process the data that we control, for how NHS England might process the data that we control for the purposes of paying our quality framework money, our QOF money, things like that. Also documents for safeguarding, how we might handle their data if there was a safeguarding request from the local council about a vulnerable patient or adult or child. So very interesting, a bit more work there, although it looks like there are some sample notices out there that practices may be able to customise and use. So I suppose that's good news.
So I think partly what we're saying is don't try and reinvent the wheel. It looks like some people are working on this as well.
Yes, look at the show notes. We'll provide some links.
Definitely.
Nottinghamshire LMC website got some good information there. They've actually pulled together a lot of good information about GDPR, so shout out to them.
Definitely. And I think also to the BMA, a lot of people criticise the BMA at times, but actually they have done some work on this to try and support practices and support GPs in terms of what needs to be done, and clearly they will be our resource that we need to look at to try and clarify it from the health perspective. Because one of the weirdest things about this is that actually a lot of the guidance has still not been formalised. So even though the deadline is literally a month away, a lot of the health aspects of GDPR is still not clear, and how that will play. For example, one of the key tenets of GDPR is actually the right to erasure of your information. And we've not covered that because that's not applicable to medical data, because you can't really go out and say, I want you to delete my entire medical record because I'm no longer at your practice. Well, then you lose the entire medical record, which is pointless, really. So there are some aspects of GDPR which don't necessarily apply to general practice in the same way that it would, for example, for a business or for a limited company or a sole trader. I guess that's one thing to remember. If you do have another role outside of being general practice that involves data, so if you control email lists, if you run a business, for example, this applies to you as well. It's not
if you run a podcast or a blog
exactly.
that collects emails from a mailing list, then you will need to pay attention to this too, or face the €20 million potential fine.
Scary.
Yeah, it was an interesting point you made there in terms of the guidelines aren't finalised, and it's always interesting to remember that this is new legislation. So sometimes, so the legislation exists, but in terms of what that means for compliance, a lot of that is only decided when some case law emerges around the legislation. So there are some questions people might ask about it that we might not know the answer to until somebody is in court as the test case. And then the application of the legislation will become clearer as judges make rulings based on it. So so fingers crossed none of us will end up being one of those test cases. But
please no. So Andy, did you have any other questions that you wanted to cover when we talked about GDPR?
Well, so it's one of those areas where I think I might have a better idea now than before I started doing research for the podcast. But there's just some questions that I think people will be wanting to ask out there that just aren't clear until you ask them. So Gandhi, will I have to regain consent from the patients I already have to hold and process their records, for example?
So the current understanding is no, you won't, because by nature of them being registered your practice, you will have implied consent in order to look after their medical data in that respect. So you don't actually have to go out and ask every single patient, can I keep your information? Because that doesn't really apply to health data. There are some exemptions on that.
That's right. So Article 61C and Article 92H deal in some part with this question, apparently. Because I went away and I had a little look at research on it. So health records are a special category of data along with genetics information and biometrics information. And that can be processed if you have one of, I think, 3 things. So any one of explicit consent from the person, or that it is necessary for the purposes of providing a medical diagnosis or provision in health and social care to the individual, then you can process that information that you hold. And there was a third one, which I think is something to do with safety and crime, but I don't have it up in front of me at the moment.
Fair enough.
But no, it doesn't appear that you have to regain consent, which is good.
And the other part, if your original consent process was suitable enough that you're only using the data for the reason you should be using it, then you don't have to go out and regain consent either. So one of the key areas that businesses are facing challenges with this is with marketing, because they hold information that could be used for a variety of different purposes, and that may not have been made clear when the person signed up 3 years ago, for example, for the service. So now they're having to go back and regain your consent, which is why you're probably getting lots of emails from various different people at the moment saying, do you still want us to be on our emailing list, for example? And some people may not need to do that because actually their original process was suitable enough to cover the current GDPR guidance and stuff.
So Gandhi, when I write a referral letter to the hospital, I communicate information from their medical record outside my own organisation. Do I need to get explicit consent?
So I don't think you need explicit consent, and from the interpretation of the guidance, that comes under what's called implied consent, because you're sharing their information for their ongoing care. And so I would want to send, for example, a patient up to NUH. I would tell them I'm referring you to the hospital. Are you happy with that? Yeah, that's implied consent. The interesting thing would be if they turn around and said, well, I don't want to go to, for example, Woodthorpe, and I then share the information with Woodthorpe. That's a bit silly and shouldn't really happen. But yeah, effectively it comes under the banner of implied consent, so I don't need to specifically have it written down that, I'm doing this.
And how about research? We do research in our practice.
Research is a bit different, I think. From my understanding of the interpretation, you do actually need specific consent for research because it's not specifically for direct patient benefit. It's not part of their actual care, which is what we're meant to be doing. It's for another purpose, and on that basis, they do have to have their exact consent, so explicit consent.
Yeah, putting my lawyer's hat on, I think that's my interpretation of this regulation as well. And finally, researcher's cousin is perhaps audit for quality purposes and quality improvement. How about that sort of activity within our organisations?
That's a bit weirder one, because sometimes it may or may not apply. I think it depends on the reason, if I remember rightly.
Yeah, I think that in those articles I quoted before, I think there is a provision that if the process is necessary for maintaining or ensuring the quality of the service, then you can do it. Obviously, you've got to be careful how far you push that, and it's yet to be interpreted in a court of law. But I don't think we need to worry about doing our own internal quality audits about if we're meeting standards and so forth, which is processing of data. But I think it's clearly a patient benefit. It's clearly internal, and it's clearly important.
So I guess the way I would see that, for example, for significant event analyses that we do, which uses patient data, because we're looking at the patient in that and discussing it with people within our organisation, and sometimes even people outside of our organisation, as long as the information is not outright shared, saying this is John Smith or blah, 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 you either anonymise the data or pseudonise the data, so put different quantifiers in there, then you should be okay to share that outside of the organisation. But you still may need to get consent, and inevitably a lot of significant event analyses you tell the patient anyway, because it's either a positive or a negative outcome for the patient.
Listeners, just go in and look at that in a bit more detail, because I think I've read something about this pseudo-anonymisation is potentially out with GDPR in terms of using the EMIS number or some kind of I think if it's possible to identify the patient by referring to a code or something, if it's possible to extract the patient identity back from the information that is exported or processed, then I think it's considered identifiable information. But hold that thought and clarify before you take any action based on that. What next, Gandhi?
Well, I mean, GDPR is coming, first of all. I think that's what we wanted to get across to our listeners today. And you need to be looking at this, simply put. And there's tons of guidance coming out and already out, and particularly the three places we would recommend that you look. One will be the BMA website. Two would be the Information Commissioner's officers, so the organisation that is actually responsible for making sure that people, not just practice, but everybody complies with GDPR. And probably your local LMC would be a really good place to have a look at. And we know that in Nottingham they've been really good. They've got really good resources, which will be in our show notes for our listeners to have a look at. But obviously you're more than welcome to look at your own LMC data and information. But the key thing is you need to be working on this now. I mean, the mapping of the workflows is a huge piece of work, and it needs to be done ASAP, really, because it's going to take you a lot of time. You need to be talking to your practice, to your admin teams, to your partners, to the people working within your practice, how that works. If you're a practice that uses a lot of locums, you need to look at access rights for those locums and how that integrates with the practice. Have you got the right process in place? And the thing to remember, a lot of practices will already have done this. A good practice that is normally complying with CQC and DPA and all that kind of stuff is probably doing this already. What GDPR really does do is clarify a lot of this stuff and makes it very clear what you should and should not be doing in a context that is not so clear for primary care. That makes sense.
And there's actually not that much difference between the previous Data Protection Act and GDPR. It's just that GDPR has more clarity and has more teeth in terms of those fines.
Definitely. Sharp razor-like teeth.
As we've been talking, Gandhi, it's become clear to me that we still have questions and that we don't have all the answers. And that really the purposes of having this conversation is just to highlight that this is something important, that there are potentially big complications for non-compliance, and it's something that people just need to be aware of and start looking at.
Yeah, definitely. I think that leads into the next area that we wanted to talk about, actually, because whilst GDPR looks clearly, and we talked about it from the practice perspective, one of the other things that GDPR is going to have a massive impact on is in terms of communication methods. So, one of the things that you may have realised from a lot of other places is that they're now asking you to look at information on gated websites and that kind of stuff. So the best example I can give is as a trainer, when it comes to information I now get about my prospective trainees, I can't be sent that in an email. I now get an email that tells me to log on to a website to access the information on protected servers. That's because GDPR also regionalizes the data servers that people use to hold all this information. And the biggest issue with that will be WhatsApp.
So that's why that's been happening. That's interesting. That's clarified that for me. So again, we like WhatsApp in my household, in the local RCGP, we use it, all sorts of places. You know, at the practice, not for patient information, of course. What's the problem with WhatsApp?
So there's a few issues with WhatsApp. I think one of the key ones is that its servers are not regionally based, so they don't have servers based specifically in the EU to process EU data. So that's one of the tenets of the GDPR, that the data has to be stored locally, and that local term will come into the EU effectively. The other part is something that is probably more applicable to our secondary care colleagues, but to a degree to our primary care colleagues as well, and that's about storage of the information held within the app. So, for example, if you take a photo on your phone and you send that through WhatsApp, that's not just stored in WhatsApp, that's also stored locally on the phone and potentially stored on other applications if you share them, and then that's kind of shared wherever you want it to. GDPR pretty much states you can't do that for information relating to effectively primary care, if we're looking at it from that perspective. So, for example, if you were to do a teledermatology and take a picture of something to share on a website like Facebook or something like that for an opinion, even if you pseudonymized it and don't have any identifiable markers, technically, you could argue that that's identifiable in some way, shape or form. And if it was to be identified, you're a bit sticky wicket, unfortunately, after 25th of May.
Gandhi, what if I put a photo on one of these websites before the 25th of May?
I have no idea, Andy.
No, neither do I. It just came to my mind. Anyway.
Let's not deal with that, because I think that's even more scary, I think. Wow. But the key thing is, and I think, the junior doctor movement was something that had huge amounts of social media and sharing and stuff. And actually, I know that a lot of our colleagues use social media to get ideas of, referral information, other ways to look at things, or appropriately with consent of the patient and stuff. But the problem is that you lose control of that data the moment that you put it out onto these kind of systems and stuff, and particularly obviously Facebook's recent events and stuff in terms of Cambridge Analytica will have a lot of people on high alert and things. Yeah. But the key thing GDPR changes is the way that you use that data, and you are now actually responsible if you start using that outside the way it should be.
So I'm going to stop using Facebook. Well, maybe I haven't used Facebook before, but I was thinking about using Facebook for getting opinions, read medical cases. I haven't, by the way, just put that out there. Or WhatsApp for that matter. What are there alternatives out there that would be compliant with GDPR?
So from a messaging perspective, that there are a few, and we were going to cover a couple of them for our listeners, basically. So the two that we've looked at is one's called Silo, so that's spelled SIILO, and the reason I'm spelling it is because it doesn't sound the way it should do, I guess. And the other one is something called Forward, which is a UK-based app that's actually just come onto the market fairly recently.
Oh, and a special shout out for our friends at Cupris. We've talked about them before and reviewed their app. That's the app for sharing photos of people's eardrums, and in the future ophthalmology pics, because they are already compliant with GDPR.
They are. So they were very smart. They seem to have seen this coming and made sure that their system by which they can share their information is GDPR compliant. Great effort there, guys.
Smart cookies.
Yep. So in terms of the messaging apps that we wanted to look at, so the first one I wanted to mention was Forward. So this is a UK-based initiative, and what it does is it basically creates a messaging system, kind of similar to Facebook, but inbuilt with that, it's also got a task management system, so basically managing your patient list. I think the first thing I'd say about Forward is it's very much secondary care focused. I don't really see this being something that would work really well in primary care, particularly since the task management aspect is very much designed about the way that you would manage a patient list in hospital. But it is GDPR compliant, so the information that's stored on it is deletable, and once it's deleted, it's gone. It's trackable, and as well as any imagery or anything, the information that you have in a video or data format is held within the app. So if you have a photo on that, it's not then automatically copied onto your device's hard drive and stuff, where it would then also need to be deleted and stuff. So it's a lot more safe and effective in that way.
Smart. Gandhi, in determining whether these apps are GDPR compliant or not, is there somebody in a position of authority who is making that judgment, or is this the interpretation of the app owners?
So far, from what I've seen, is the interpretation of the app owners. However, the ultimate authority, as we mentioned earlier, for the UK will be the Information Commissioner's Office. So both of these apps have basically got something on their website that says that we've kind of run this by the ICO and they seem happy with it and stuff.
That's fantastic. That gives me some level of reassurance. Good. Yeah.
So forward looks really good, although like I said, although it works quite well and quite effectively, it very much is, I think, a secondary care based application, and I think we wanted to just make that clear when we looked at it. And there are very similar kind of alternatives, so Hospify comes up as a good alternative to that, and maybe worth a look at if you're in the secondary care teams or if you're working in teams whereby particularly the list element is important. I think for primary care, Silo is probably a better version to look at, and the simplest way I can describe this is WhatsApp that's GDPR compliant, and they've got a large user base, 500,000 users from their downloads and stuff, which, if you compare that to WhatsApp's 3 billion odd, is nothing. However, it's obviously quite large in that context, and you can actually find people that are on Silo in your local area. So I've logged in and used it. I've been able to find there's a couple of people over at NUH that are also using it. I'm not going to give out their names, don't worry.
Have you asked them for an opinion?
I haven't yet, because I don't actually know who they are. Yeah. That's the thing. So I thought it'd be a bit weird saying hi, how are you, kind of thing. But
it would, wasn't it?
Yeah.
Can you see these apps being adopted by CCGs? Accountable care systems as a way of improving communication between primary and secondary care, or setting up some approved routes for sharing photos, ECGs, things like that. Can you see that happening?
I think if they were smart, this may be something they need to consider looking at. So particularly a lot of teledermatology systems will use methods of sending information and data via different routes, and traditionally that used to run on an email system. Well, emails unfortunately can be GDPR compliant because as long as it's kept within its own ecosystem and that kind of stuff, but it's not as secure, I don't think, from my perspective, and I think the ICOs
and the user experience of some of those teledermatology systems is fairly poor as well, in terms of the number of steps to get the information across. It just strikes me that, like with something like Silo, the CCG could set up some information sharing groups. You could take a picture on your own device or a provided device, be assured that you're complying with regulations, send it forwards for an opinion and get a response back either via your clinical system or via the app. It'd be very good. I think we should be lobbying the CCGs, perhaps.
Yeah, maybe they'll listen to us for once.
Yeah.
So yeah, the apps hopefully will give you some grounding to start looking at other methods. That isn't to say you can't actually use WhatsApp. So obviously, personally, this is perfectly fine for you to use. And actually, I'd argue as a business element of the practice, there's nothing to say you can't still use WhatsApp as a communication method, as long as you do not use any patient identifiable information on there. That's the key thing. And this is obviously a tenet that's always existed, but it's just one that becomes a lot more clearer. And I think particularly the whole aspect of sharing imagery on WhatsApp is probably something that needs to really be looked at. So, pictures of a funny wart or something like that maybe, even if you've consented the patient, I'd be really hesitant about using them. So we covered quite a few things today. We apologise if you may have found it slightly drier than our normal stuff, but GDPR is a heavy thing that we wanted to talk about, and I think it's worried us, and we kind of figured it'd be worrying some of our listeners and stuff, and wanted to just try and demystify it a little bit. Kind of reassure you it's probably not as bad as you're thinking it is, but there is work that you need to do in order to make sure it's not as bad.
So I certainly feel a little bit better for having aired some of my worries in public about GDPR, and hopefully it won't turn out to be as bad as we think.
No. As we said, a lot of the resources that we've been looking at will pop up in our show notes, so please feel free to have a look at them. And we've got some interesting stuff planned for next time, haven't we, Andy?
Yes, we have. So a few months ago, I swabbed the inside of my cheek. I put it inside a little device and I sent it off to Holland to have my genome sequenced by 23andMe. And I've got the results back. And in the next exciting episode, we'll be talking about personal medicine, personal genomics, and all things to do with an area that is perhaps unfamiliar for us in terms of wet medical technology. So that'll be interesting.
Sounds it. I know it's something we've talked about in the past between us, and Andy was very much the pioneer out of the two, as I'm very hesitant and reluctant to kind of look at this kind of stuff. But yeah, let's see where we go next time.
Let's see.
Okay. Thanks again to our listeners. We hope you've enjoyed our show. As we would like to make absolutely clear, the GDPR stuff, please remember we are not by any means experts on this, and we're just kind of muddling our way through, as many of you are. But feel free to follow us on Twitter, on our websites, and on obviously our podcast, which is now being hosted on Podbean. And hopefully you'll be able to listen to us next time.
Yeah, so thanks for listening. Take care, guys. See you soon.
See ya. Bye.